Dr. Mitchell couldn't stop smirking when he spotted the tattoo on the new nurse's forearm. "What ridiculous tattoo," he laughed loud enough for half the emergency department to hear. The intricate design looked like military nonsense to him. Probably some wannabe soldier playing dress-up in scrubs. "Did you get that at some strip mall parlor?" he continued, his voice dripping with condescension. Sarah Bennett kept her eyes down, continuing to check the medication cart. She'd heard worse. The tattoo was small, elegant, but apparently screaming for attention. According to Dr. Mitchell, what he couldn't read were the subtle symbols woven into the design. Symbols that would make most military personnel straighten their spines and show immediate respect. Director Thompson happened to walk by at that exact moment, catching sight of Sarah's exposed forearm as she reached for supplies. His face went completely pale. His steps faltered, then stopped entirely. That wasn't just any tattoo. Those weren't random military symbols. The eagle, the specific arrangement of stars, the subtle medical cross integrated into the design. He recognized it immediately. Special Operations Leader. He whispered under his breath, his voice barely audible. Dr. Mitchell was still chuckling when Director Thompson approached, but his laughter died quickly when he saw his boss's expression. Something had shifted in the room's energy. Something serious and immediate. Sarah had spent 3 tours in Iraq as a special operations medic, leading teams in the most dangerous combat zones. She'd performed surgery in caves with nothing but a headlamp, saved dozens of lives under enemy fire, and trained elite soldiers in advanced trauma care. But here, in this civilian hospital, she was just another nurse to mock. The irony wasn't lost on her. These doctors saw scrubs and assumed incompetence. They saw her age and assumed inexperience. They saw her quiet demeanor and assumed weakness. None of them knew that her steady hands had performed more life-saving procedures in impossible conditions than most of them would see in their entire careers. But what happened next would change everything in that hospital. If you want to see how Sarah proves everyone wrong about what that tattoo really means, make sure you subscribe to Emergency Hero Stories, because what she does in the next few minutes will leave you speechless. Where are you watching from? Because what Sarah did with those steady hands was about to redefine everything they thought they knew about combat medicine. The trauma bay doors exploded open as paramedics rushed in, a victim from a multi-car accident. Male, approximately 35, massive chest trauma, possible internal bleeding. The lead paramedic shouted over the chaos. Blood pressure dropping fast, pulse weak and thready. Dr. Mitchell immediately took charge, barking orders as the patient was transferred to the trauma bed. "Get me 2 large bore IVs type and cross for 6 units of blood and somebody call surgery." His hands moved quickly over the patient, but Sarah could see something in his eyes. Uncertainty masked by authority. Sarah stepped closer, her trained eyes immediately assessing what the others were missing. The patient's positioning, the specific pattern of bruising, the way his breathing had changed in the last 45 seconds. Her military training kicked in automatically, reading signs that civilian medicine rarely encountered. "Doctor, I think you should consider..." Sarah started to speak, but Dr. Mitchell cut her off without even looking up. "Nurse Bennett, I need you to get supplies, not give medical advice," he snapped, his earlier mockery still fresh in his voice. "This is a level 1 trauma, not a place for suggestions from support staff." The patient's vitals dropped suddenly. The monitors began their urgent beeping as blood pressure plummeted and heart rate spiked erratically. Sarah watched Dr. Mitchell's movements become more frantic, less precise. She'd seen this before. Good doctors overwhelmed by trauma they hadn't trained for, missing critical signs because they'd never worked under true combat conditions. Director Thompson stood in the doorway, observing everything. He watched Sarah's posture, the way she read the monitors, how her eyes tracked every detail of the patient's condition. This wasn't casual observation. This was tactical assessment from someone who'd managed mass casualties under fire. "He's bleeding into his chest cavity," Sarah said quietly, stepping closer to the bed. The impact pattern suggests a steering wheel injury, but there's something else. His left lung is collapsing, and there's likely damage to the great vessels. Dr. Mitchell glanced up irritably. I can see the obvious trauma, nurse. What I need is supplies and assistance, not a running commentary. But his hands hesitated over the patient, uncertainty creeping into his voice. Sarah's eyes met Director Thompson's across the room. She saw recognition there, and something else. Permission. 3 tours in Iraq had taught her when to speak up and when to act. Lives hung in the balance, and protocols became secondary to survival. The patient's breathing became more laboured. His skin colour was changing, taking on the greyish pallor Sarah had seen too many times in combat zones. They had minutes, maybe less, before this became irreversible. Dr. Mitchell. Sarah's voice carried new authority, though still respectful. In my experience with similar trauma patterns, there's likely a torn blood vessel near the heart. Standard protocol won't be enough. This patient needs immediate surgical intervention, but first we need to stabilise the bleeding. Your experience? Dr. Mitchell's voice was sharp with sarcasm. What experience could a floor nurse possibly have with trauma surgery? Director Thompson stepped forward, his voice cutting through the tension. Dr. Mitchell, I think you should listen to what Nurse Bennett has to say. The monitors screamed as the patient went into shock. Blood pressure crashed to critical levels, and his pulse became barely detectable. Dr. Mitchell's face went white as he realised this was spiralling beyond his control. Standard emergency protocols weren't working, and precious seconds were slipping away. Sarah stepped forward without waiting for permission. Her movements were different now, precise, confident, with the kind of calm authority that comes from managing life and death under impossible conditions. Director Thompson, with your permission, I'd like to assist with this patient. What the hell is going on here? Dr. Mitchell demanded, but his voice cracked with uncertainty. The patient was dying in front of him, and nothing he'd tried was working. Director Thompson nodded to Sarah. Show them. Sarah's hands moved with practiced efficiency, her military training taking over completely. She positioned herself at the patient's side, her movements economical and purposeful. This patient has a tension pneumothorax with probable hemothorax, complicated by what appears to be cardiac tamponade. We need to address all 3 issues simultaneously. Her hands found the precise location on the patient's chest, feeling for landmarks that most civilian doctors only read about in textbooks. In combat zones, she'd performed this procedure dozens of times with nothing but battlefield conditions and improvised tools. I need a large gauge needle, sterile prep, and surgical tools for a chest tube placement, she directed, her voice carrying the unmistakable tone of someone accustomed to being obeyed in life-threatening situations. Dr. Mitchell stared in disbelief. You can't just perform procedures. You're not qualified to... Doctor, Sarah interrupted, her eyes never leaving the patient. I've performed emergency thoracostomies in forward operating bases under enemy fire. I've managed mass casualties with no backup and limited supplies. This patient has the same injury pattern I've seen in IED blast victims. She began the chest decompression procedure with movements so smooth and confident that everyone in the trauma bay fell silent. Her hands moved with surgical precision, finding anatomical landmarks through touch alone, placing the needle with absolute accuracy. The immediate release of pressure brought colour back to the patient's face. His breathing improved dramatically, and the monitors showed stabilising vital signs. But Sarah wasn't finished. The bleeding is still active, she continued, her hands already moving to the next intervention. He needs emergency surgery. But first, we need to control the hemorrhage and address the cardiac issue. Dr. Mitchell watched in stunned silence as Sarah continued working. Every movement was textbook perfect, but performed with a speed and confidence that spoke of extensive real-world experience. This wasn't theoretical knowledge. This was muscle memory developed through repeated life-saving interventions. Director Thompson moved closer to Dr. Mitchell, his voice low but clear. That tattoo you were laughing at, it designates Special Operations Medical Leadership. She saved more lives in combat conditions than most doctors see in their entire careers. Sarah continued her assessment, her trained hands detecting subtleties that others had missed. The cardiac silhouette is enlarged, suggesting blood in the pericardial space. We need to prepare for emergency pericardiocentesis if his pressure doesn't stabilize. The patient's vital signs continue to improve under Sarah's interventions. What had seemed like an impossible case minutes earlier was now stabilizing rapidly. Her combat-tested techniques were working where standard protocols had failed. "How did you know?" Dr. Mitchell asked quietly, his earlier arrogance completely gone. Sarah looked up briefly, her hands never stopping their work. "In Iraq, we saw this injury pattern regularly from vehicle-borne IEDs. The steering wheel impact creates a specific constellation of injuries that civilian medicine doesn't encounter often. Military medicine teaches you to recognize and treat what kills fastest." The trauma team worked under Sarah's quiet direction, now following her lead as she guided them through interventions they'd never performed before. Her military experience had seamlessly translated to civilian medicine, bringing techniques and insights that were saving this patient's life. Within 25 minutes, the patient was stable enough for transport to surgery. Dr. Mitchell stood back, watching Sarah complete her documentation with the same methodical precision she'd shown during the emergency intervention. The trauma bay, which had been chaotic and desperate just moments before, was now calm and organized. "I owe you an apology," Dr. Mitchell said quietly, approaching Sarah as she cleaned up her equipment. "I had no idea about your background." Sarah looked up from her work, her expression neither bitter nor triumphant. "You weren't supposed to know. Most people see the uniform, not the person wearing it." She paused in her work, meeting his eyes directly. But that patient didn't care about assumptions. He needed someone who could read trauma patterns and act decisively. Director Thompson joined their conversation, his respect for Sarah evident in his voice. Dr. Mitchell, Nurse Bennett, served 3 combat deployments as a special operations medic. She led medical teams in forward operating bases and trained elite soldiers in advanced trauma care. The weight of Sarah's qualifications settled over Dr. Mitchell like a revelation. He'd been condescending to someone whose medical experience under pressure far exceeded his own. The embarrassment was obvious on his face, but Sarah's expression remained professional and understanding. "The transition from military to civilian medicine isn't always smooth," Sarah explained, returning to her equipment checks. "Combat medicine is about doing whatever saves lives with whatever resources you have. Civilian medicine has protocols, hierarchies, proper procedures. Both approaches have their place." Dr. Mitchell shook his head, still processing what he'd witnessed. "What you did in there, I've never seen anything like it. The speed, the precision, the way you read the patient's condition. How do you develop that level of skill?" Sarah's expression grew thoughtful. "You learn by necessity. When someone's bleeding out and the nearest hospital is 100 miles away through hostile territory, you develop skills quickly or people die. Every procedure becomes muscle memory because there's no time to think or second-guess yourself." She began gathering her supplies, her movements still demonstrating the efficient economy of motion that marked her military training. "In special operations medicine, we're trained to handle everything from routine care to emergency surgery. You become the entire medical team because often you're the only medical professional for miles." Dr. Mitchell watched her work, seeing details he'd missed before, the way she organized her supplies, how she'd positioned herself for optimal patient access, the systematic approach to assessment and treatment. These weren't random actions. They were the result of extensive training and experience. "That tattoo," he said quietly. "I completely misunderstood what it meant." Sarah glanced at her forearm, where the intricate design was now partially covered by her sleeve. It represents completion of special operations medical leadership training. It's not just about individual skills. It signifies the ability to lead medical teams under combat conditions, train others, and make command decisions when lives depend on it. Director Thompson added context that made Dr. Mitchell's earlier behavior even more inappropriate. Special operations medics undergo some of the most rigorous medical training in the world. They're trained to perform procedures that would challenge experienced surgeons, often under conditions that would paralyze most civilian medical professionals. The patient's successful stabilization spoke to the validity of Sarah's approach. But more than that, it demonstrated the value of diverse medical backgrounds and experiences. What had seemed like arrogance from Dr. Mitchell's perspective was actually life-saving expertise applied at exactly the right moment. Later that evening, Sarah was completing her shift documentation when Dr. Mitchell approached her workstation. The emergency department had returned to its normal rhythm, but the events of the trauma bay continued to resonate through the staff. "I wanted to talk to you about what happened today," Dr. Mitchell began, his voice carrying none of its earlier condescension. "Not just to apologize, but to understand better. I've been thinking about that case all afternoon." Sarah looked up from her computer, her expression open and professional. "What specifically were you thinking about?" "The way you read the patient," Dr. Mitchell said, pulling up a chair beside her desk. "You saw things I missed completely. The injury pattern recognition, the immediate understanding of what interventions were needed. That level of assessment doesn't come from textbooks." Sarah saved her documentation and turned to face him fully. "Combat medicine teaches you to see patterns and make decisions quickly because delayed recognition means death. When you're managing casualties from IED explosions or sniper attacks, you learn to read trauma in ways that civilian medicine doesn't typically require." Dr. Mitchell leaned forward, genuinely interested in learning. "Can you teach that kind of assessment? I mean, could civilian doctors learn to recognize those patterns?" "Absolutely," Sarah replied without hesitation. "The principles are the same. It's about systematic assessment, pattern recognition, and decisive intervention. Military medicine just compresses the learning timeline because the stakes are immediate and constant." She pulled up the patient's imaging on her computer screen, pointing to specific details. "Look at this rib fracture pattern. In civilian medicine, you might see this once or twice in your career. In combat zones, this exact pattern appeared regularly in vehicle blast injuries. Once you've managed 50 cases like this, you recognize it immediately." Dr. Mitchell studied the images, beginning to see what Sarah had identified so quickly. "So, it's experience-based pattern recognition. You've seen these specific injury combinations enough times to know exactly what to expect." "Exactly. And more importantly, you've learned what kills first and what can wait. Triage becomes instinctive when you've managed mass casualty events, where you're treating dozens of injured soldiers simultaneously with limited resources." Sarah's explanation was helping Dr. Mitchell understand not just what she'd done, but why her approach had been so effective. Military medicine wasn't just different, it was complementary to civilian practice, offering insights and techniques that could benefit everyone. "Would you be willing to share some of that knowledge?" Dr. Mitchell asked. "Maybe lead some training sessions on trauma assessment or emergency procedures?" Sarah considered the proposal thoughtfully. "I think that could be valuable. Military and civilian medicine have different strengths. Combining those approaches could improve patient outcomes for everyone." Director Thompson, who had been listening from nearby, joined their conversation. "I've been thinking the same thing. Sarah, would you be interested in developing a trauma training program that incorporates military medical techniques? We could use your expertise to enhance our emergency response capabilities." The offer represented recognition not just of Sarah's skills, but of the value that diverse medical backgrounds brought to civilian healthcare. Her military experience, which had been dismissed and mocked earlier that day, was now being recognized as a valuable asset for the entire hospital. "I'd be honored to contribute," Sarah replied. "There's a lot that military medicine can teach civilian practice, and vice versa. The goal is always the same: saving lives and providing the best possible care." Dr. Mitchell extended his hand to Sarah, his expression sincere and respectful. "I'm sorry about this morning. I made assumptions that were completely wrong, and I let my prejudices cloud my judgment." Sarah shook his hand, her response gracious and professional. "We all make assumptions sometimes. What matters is what we do when we learn new information. Today showed me that this hospital values expertise wherever it comes from." 4 months later, Sarah's trauma training program had become one of the most requested educational offerings at the hospital. Dr. Mitchell, now one of her most dedicated students, had incorporated military-style assessment techniques into his practice with remarkable results. The program attracted medical professionals from throughout the region, eager to learn combat-tested approaches to emergency medicine. Sarah's teaching style reflected her military background, systematic, practical, and focused on developing skills that could be applied immediately in high-pressure situations. The key difference, Sarah explained to her latest training class, is that military medicine assumes the worst-case scenario and prepares for it. We don't hope for the best. We plan for the most challenging possibilities and train until those responses become automatic. Dr. Mitchell, now serving as Sarah's co-instructor, added his perspective from the civilian side. What Sarah is teaching us is that preparation and pattern recognition can dramatically improve patient outcomes. The techniques she's sharing aren't just military medicine, they're advanced emergency medicine that we can all use. The partnership between Sarah and Dr. Mitchell had evolved into mutual respect and collaborative learning. His civilian medical training complemented her combat experience, creating a comprehensive approach that benefited both instructors and students. Director Thompson observed their training sessions regularly, consistently impressed by the practical skills being developed. Patient outcomes in their emergency department had improved measurably since implementing military-derived protocols and assessment techniques. Sarah's program has changed how we approach trauma care, Director Thompson explained to visiting medical administrators. "We're seeing faster recognition of complex injuries, more decisive interventions, and better coordination during mass casualty events. The military medical model brings discipline and systematic thinking that enhances everything we do." The success of the program had attracted attention from other hospitals and medical institutions. Sarah regularly received invitations to speak at conferences and lead training programs throughout the country. Her expertise, once dismissed and ridiculed, was now recognized and sought after by medical professionals everywhere. But perhaps the most significant change was in the culture of the emergency department itself. Sarah's quiet professionalism and demonstrated competence had shifted how everyone thought about assumptions and first impressions. The lesson extended far beyond medical procedures. It touched on respect, recognition of expertise, and the value of diverse backgrounds. Dr. Mitchell often reflected on that first day, remembering his dismissive attitude towards Sarah's tattoo. What he'd seen as a ridiculous decoration had actually represented years of advanced training and life-saving experience. The memory served as a constant reminder about the dangers of judging people by surface appearances. Sarah continued her work as a floor nurse, but now she also served as the hospital's trauma consultant and training coordinator. Her military experience had found its proper place in civilian medicine, not as a replacement for existing protocols, but as an enhancement that made everyone more effective. The tattoo on her forearm remained the same, but now everyone who saw it understood its true meaning. It represented not just individual achievement, but the dedication to saving lives that connected military and civilian medicine. Sarah had proven that expertise comes in many forms, and the most valuable contributions often come from the most unexpected sources. In the end, the ridiculous tattoo had become a symbol of excellence, respect, and the transformative power of recognizing talent wherever it exists. Sarah's journey from mocked newcomer to respected leader demonstrated that sometimes the people others underestimate are exactly the ones who can teach everyone else the most valuable lessons.